Welcome. This is the very last COVID of the year. And as usual, the meeting is being recorded and live streamed on the KDHA channel. So it's great to see everyone. Thanks for being here. I think I know everybody knows me here, but my name is Jimena Garcia. I'm the governor's senior advisor for vaccine equity, and I'm going to be leading this discussion today with Dr. Kali Akers and her team, and also my colleagues from KDHE. So the bulk of today's meeting is going to be spent hearing from a panel that we have convened made up of local, state, and regional public health experts from Kansas to hear what they think is next for health equity and public health. So I'll just do a quick review of the agenda and then we'll jump in. So we're going to start with introductions. Then we're going to have Jamie Gable, senior epidemiologist at KDHE, review the latest COVID vaccine data now that we're a few months into having the new vaccine. After that, we're going to move into the panel where we're going to have Charlie Hunt, Jade Ramsdell, Christy Kane, and Captain Kim Davids. And then we're going to have announcements and then adjourn. So let's see, why don't I pass the floor? Oh, no, sorry, we're going to do introductions. So if there's anybody on this call that's new and you feel like it, please come off mute and introduce yourself and tell us a few words about what you're passionate about. And then people who are returning who have been here before, if you could please put your name and organization in the chat. So is there anybody new today that would like to say hello?
I'm not sure I understand.
Oh my gosh. Sorry. Okay, great. Why don't we just move along to the next thing? So I'm going to pass the floor now to Jamie Gable, senior epidemiologist at KDHE, to share the vaccine rates with the new vaccine. Thanks, Jamie.
Thanks, Dr. Garcia. So we're continuing our look at data that's focused on the updated 2023-2024 COVID vaccine. So we're looking at who currently has vaccine-induced protection from severe illness in Kansas. Numbers have grown some since October. Some of them are still looking a little low, as you can tell. And these, the total Kansans with the updated formula is available on our dashboard that we update monthly, and we will be rolling out a redesigned dashboard in the coming weeks. So the first slide is looking at an overview of vaccine uptake in Kansas as of November 1st for the 2023-2024 updated COVID-19 vaccine formula. About 5% of all Kansans have received an updated dose, and last month that was about 2%. So we did see that more than double. And we're still in a period where we can expect to see those numbers grow quite a bit in the next month. Adults age 65 plus have the highest coverage at 17.9%, which is actually more than 10 percentage points higher than last month's coverage, which was 7.4%. Next slide, please. So this slide, we're looking at the updated formula uptake across different races and age groups. Native data here is consistent with what we had been doing our past few meetings, and it reflects anyone who has indicated Native is at least one of their races. Native Kansans have the highest coverage for all age groups. White Kansans have the second highest coverage for adults and older adults, while Asian Kansans have the next highest coverage for children. Hawaiian Pacific Islander Kansans tend to have our lowest coverage in all the different age categories. In many cases, the coverage for total Kansans, you can see, is higher than any of the individual race categories. This is because we have a number of individuals that are either categorized as unknown race or multiracial. So they're counted in the total Kansan number, but unless one of their races are native, they're not included in the individual race breakdown. So that kind of helps explain why you might see a much higher number for total than you do for any individual race. Next slide, please. So as we look at the ethnicity slide, I just wanted to remind everyone that when we calculate the race, it's independent of ethnicity, and when we calculate ethnicity, it is independent of race. So we have those on separate slides to help make that distinction. And to explain what I mean by that, when we look at that, it means if somebody were Black and Hispanic or Latino, they would be included in both the rates for Black on the previous slide and then Hispanic and Latino on this slide. This slide is organized similarly to the previous slide, but we're looking at ethnicity instead of the race. For updated COVID-19 vaccine, Hispanic Latino Kansans tend to have lower coverage than non-Hispanic Latino Kansans, And that's been consistent for each month that we've looked at the new vaccine. But we do know that for the original pandemic vaccine that came out, we saw that for one dose, Hispanic Latino Kansans actually had higher coverage. So the numbers are kind of still looking a little bit low across the board, but the difference in 18 plus Kansans is the widest between Hispanic and non-Hispanic. And the difference in coverage for 55 plus age group is about 2 percentage points, and the overall coverage for children under 18 is very low for everyone. So it's really hard to really see how big that gap is. So that's what I have today for our update. Thank you for having me. And as always, please feel free to reach out with any questions.
Thank you so much, Jamie. Yeah, those numbers are, I mean, they're just so low across the board, and I'm glad they're higher for older adults, but it's, I hope that they're going to keep going up, and, everybody on this call is working on that. So thank you. Obviously the work still needs to happen. Okay, so I just wanted to share a couple of resources I found. So I think most people on this call have heard me maybe talk and wish that we had some tailored materials, like putting out information about the Bridge program, because now that vaccine is not free across the board, people without insurance can access it through the Bridge program, and it's just really knowing that it's there. And until now, I really hadn't seen specific material that's culturally relevant for different groups. So I'm going to send out these slides so you'll have these websites, but I just wanted to share what they are, and then just a couple examples of what comes out of them. So the first one is Vaccinative, and their materials are all made by Native people for Native people. And then the following three are from the California Department of Public Health, and all of these organizations said it's fine to co-brand their materials and modify and change to suit you. So these are like communications toolkits that are ready to go, so that community groups or whoever wants to use them can post it on social media and so forth. And we know that the message is sometimes better received about COVID vaccine when it's not from a government organization. So we really count on community-based organizations to share this kind of information, and this makes it really easy. So if you could go to the next slide, please. So this is an example from the Vaccinative toolkit, and oh my gosh, this toolkit is so comprehensive. It has PowerPoints ready to go for providers and people that want to like share information about vaccine hesitancy, so forth and so forth. It also has video clips that you can post and all kinds of things. So I would encourage you to get on that site and look. And next slide, please. The next couple slides. So these are just examples from the California Department of Public Health. And like I said, they said it's fine to co-brand stuff and use it. Next slide. And they have a lot of stuff about RSV and the flu. We're thinking of all these viruses sort of as respiratory virus season. And so there's a lot of information that you can use for that. And then this is just an example. The California Department of Public Health stuff is available in a whole bunch of different languages also, in case that's something that you need. And Shelley would love to help with the materials. Thank you. Thank you so much for that. Okay, next slide. So I'd like to pass the floor now for the rest of the meeting to Dr. Kali Akers to lead the panel discussion.
Thank you, Dr. Garcia. We are really excited to have a panel discussion to close out our year in COVID. As we were reflecting on sort of where we've been over the last year, we thought it was a good occasion to engage some of our partners at the local, state, and regional level in thinking about sort of the journey we've been on with COVID and where public health goes from here as sort of a year end. So before I take down the slides and make sure we have our speakers spotlighted, I just wanted to note we're really excited to be joined by 4 panelists. They all have lengthy and illustrious previous careers in public health, and relatedly lengthy bios that I could spend a fair bit of the rest of our time reading. So I'm going to actually give the abridged version and refer you all to Dr. Garcia's email yesterday, which contains their lengthier bios. But we're excited to be joined today by Charlie Hunt, who is currently the director of Johnson County Department of Health and Environment, Jade Ramsdale, who is the Performance Improvement Director at KDHE, Christy Kane, who's Director of Local Public Health Program at KDHE, and Captain Kimberly Davids, who is the Acting Regional Health Administrator for the Office of the Assistant Secretary for Health in Region 7. Thank you all for joining us today. We are very grateful for that. Part of our conversation, sort of the origins of this group have really been in COVID-19 vaccination. So it seems like a natural starting place for our conversation today. Reflecting on the last few years, we're interested in getting the conversation started by thinking about the lessons you've learned from our COVID-19 response, mitigation, and recovery efforts. So I'd like to start by thinking what are those lessons learned, and then maybe if you wouldn't mind talking about how that influences how you look at the future for public health. And Captain Davids, I was wondering if you might get us started.
Yes. Good afternoon, everyone, and thank you so much for the opportunity to be here and sit on this panel and kind of bring a federal perspective to this. So what we saw during COVID was that all of the inequities that we knew existed, but they were really just exacerbated with the pandemic. And we saw that with, cases and hospitalizations and deaths. We also saw it with trying to roll out the vaccine to different communities. And so from the pandemic, when this administration came on board, kind of the first executive order that they put into place was advancing racial equity and support for underserved communities. And that really was a call to all federal agencies to work together to have a comprehensive approach to advancing health equity. And so we're trying to do that on the federal side. We have established like a Region 7 federal health equity work group. Initially, this was established looking at vaccinations and how we could get them into communities in the region that had high social vulnerability index, but low vaccination rates. And so we actually were able to work with our states and get some community conversations. And that's how I got connected with Dr. Garcia. And we ended up expanding that regional federal health equity work group to our state partners, our state minority health offices. And we come together, we meet once a month and really just talk about lessons learned and best practices and how we can apply health equity into all of our public health initiatives. And so really that being at the forefront, moving forward instead of as an afterthought. Thank you.
Thank you. Jade, Christy, I wonder if you might speak to the state level, sort of what are those lessons learned from the response, mitigation, and recovery efforts, and how does that shape your thoughts about the future for public health?
Jade, would you like to go first?
I'm more than happy to. Thank you so much, Christy. Yeah, I think it's enabled us to really think about agility and flexibility a little bit different. One of the things that was really underscored during the pandemic was the support that was needed for our public health workforce. We've seen, there was a survey that indicated that over a 5-year period, 2017 to 2021, we saw a 50% turnover of our workforce. And so with that, we're really thinking differently about how we recruit, how we retain, how we ensure inclusion throughout our department, ways in which we are helping to support our staff members. In that same survey, 32% of folks were saying that they would leave the workforce within a year. So we know that the pandemic really highlighted the burnout, really highlighted that, we have a lot of opportunities to grow our workforce and really recruit in folks that are possibly from different sectors and shed some light on why this public health work is so critical and so important. I will also say that another thing that was emphasized with this work is regarding mental health and well-being of our workforce and ways in which we can best support our staff. For us here at the department, we're really looking at different angles to make sure that our staff feel supported. And it's been a really great lever for recruitment as well for us, because we're really centering how equity, inclusion, and mental health and well-being are intertwined.
Thanks, Jade. Christy, do you want to add from the state perspective?
Sure. I definitely should have gone first because Jade took my thoughts. No. Yeah, I agree with what Jade said. I mean, definitely. So my program works directly with the local health departments and provides training, technical assistance, and any other needed support to the 100 local health departments across the state. And we saw really the same thing that we saw at KDHE, a lot of turnover. We lost about 42% of our local leaders, either our health officers or those serving as public health, local health department directors, or those serving in a dual role. And so for those left, really focusing on their mental health and their well-being, encouraging self-care. So really focusing on retention. And I think one of the things that we need to do is take advantage of some of the things we learned during the pandemic. So for example, one of the things that we learned on my team is that people can work successfully remotely. And so now I have a team. I've got 2 team members who are on the Colorado border. And so that we can really grow our agency and have really solid, capable people working they're not from Topeka and they don't come to the office every day. And so just really doing a work from home policy or hybrid so that we can recruit a more diverse workforce. And I think we've shown the investment in public health makes a difference. There was a lot of funding that went into public health that was unprecedented. And we are on the verge of more unprecedented funding that we're getting ready to roll out through the Public Health Infrastructure Grant. And so I would just say there's so many new opportunities. It's a time to be innovative and transformational with public health. I think selling public health, we got kind of a negative rap during the pandemic. And so how can we build from there and learn from that and just come up with an effective way to sell what we do to the general public and to policymakers. And I definitely think that if we focus on the behavioral health of our public health staff, it will benefit communities in the long run.
Yeah, thanks, Christy. Charlie, do you want to weigh in at the local level?
You bet. And I agree with everything that's been said. You know, I think it's probably worth pointing out that when COVID first hit, I was actually with the Kansas Health Institute. And so I was not working directly with the local health department, but my role there as an organization, we made the decision to provide some support to KDHE. At the time, we had 2 former state epidemiologists on staff, Dr. Pizzino, who was also a health officer for Shawnee County at the time, and then myself. I had spent some time at KDHE as a state epidemiologist. So we decided as an organization to provide some technical support and assistance to KDHE. And you know, from that perspective, I could see a lot of the challenges that local health departments were and KDHE were working through. But I joined Johnson County in June of 2021 when if you think back, really at that time the things were getting a lot better. And I often joke that I was just going to ride that epi curve on out and take it easy. But of course the fall hit and things turned around really quickly. But I will tell you that the kinds of things that Jade and Christy in particular were talking about with respect to the toll that the response took on the local and the state public health workforce and the federal level as well was real. It was very difficult, very challenging circumstances. And so I agree that we have to continue to provide a lot of support because the reality is this is not the last big thing that's going to happen. We might not have anything on this scale for our while, maybe even in our careers or lifetimes, but there are always going to be things that are coming along. And I think it's going to take a long time for us to fully recover from this. I think the other thing I'll mention with respect to lessons learned about the response, and specifically I'll talk about the vaccine rollout, is that I think that we learned that it's important to make sure that we are rolling a campaign out, the strategies out in a way that we are not leaving anyone behind. And so I'm also going to say that I'm speaking from the perspective of a large health department. Johnson County has over 600,000 residents, and so we're a large department. But the strategy that was implemented here was to do these very large vaccine events in warehouses, in gymnasiums, and so forth. And a lot of people don't want to come to those kinds of events, and we were, I think, probably focused on that, but also the importance of making sure that we are working with community groups, with churches, with local organizations, to make sure that we're not leaving anyone behind. I can tell you from my own experience, my mom, who is elderly, and just getting signed up to get the vaccine, the technological aspects of it, of going onto the website and making sure everything's done. I helped her through that, and fortunately I was able to do that, but not everybody has somebody close to them that's able to do this. We've got to make sure that we've got the strategies in place to reach people from an equity perspective.
Thank you, Charlie. Thank you all for reflecting on sort of those lessons learned. Thinking now to the future, what opportunities do you see for public health, and opportunities to grow, opportunities to change? What comes to mind? And Charlie, I know we ended with you, but I'm going to put you back on the spot to start us off on this question.
Sure. Well, and Christy alluded to it a little bit, and that is the resources, the additional resources that came in. So I think that again, it is unprecedented, and I'm very hopeful that we'll be able to maintain a lot of the capacity and frankly the capabilities that we were able to build up as part of the response. For us in particular in Johnson County, the kind of the lasting impact of this is, first of all, we greatly expanded our epidemiology capacity and capabilities here. So we now have an entire epidemiology division. And that was an opportunity that presented itself during COVID that we were able to take advantage of. We also have developed a community health worker program, starting with RADx up, and now with COPE project through KU. And we're using the infrastructure funding that Christy mentioned to continue that program for a time. So I'm hopeful that we'll find the resources to keep it going even beyond the infrastructure grant, because, and in terms of equity, having a program like community health workers that are able to really relate, and they come from the community, they relate well to community members. To me, I think that's a really important part of our program. And so I think that's an opportunity. The other thing that I'll mention, and Christy talked about kind of the negative, the bad rap that public health got, and that's true. But it also put public health in the spotlight, and I think that we've got the opportunity to take the spotlight we've been given. And the focus is not so much on COVID anymore in terms of the public's mind, but certainly they understand a little bit better about some of the things that public health does. Not everything. I think that there's a lot of things that public health does that people still don't really truly understand. But I think that we've got to take the opportunity with all the focus that was placed on us, and turn around and help explain how we support and help the communities that we serve through all of our other programs and services. And so I think that's a really good opportunity. And of course, all the partnerships that were either formed or strengthened during the COVID response, I think is a really good opportunity for us.
Thanks, Charlie. Other panelists, do you want to weigh in on opportunities?
I'm happy to share some opportunities. So I know that one of the challenges during the pandemic was communication, like especially from federal to state to local, and then local back to state. And so I think we've developed a lot of new venues during the pandemic that didn't exist before, that allow us to share information, not only with local health departments, but also key partners. And so one of those is Public Health Power Hour, where we feature a topic every Monday at 3 p.m. And I'll drop the links to register for these in the chat if you're not familiar. We also do weekly updates for local health departments. During the pandemic, they were daily. I'm not quite sure how we did that, but we did. But now they're weekly. And so they're every Wednesday at 3 p.m. And it's an opportunity for some of you, if you have information that would be helpful to share with the local health departments, you would be welcome to come on and share that information. And there are also a lot of trainings and things like that that are featured. And so you would be welcome to attend. And then we have our KDHE has local partner updates every Thursday at 10 a.m. And then we also do regional public health meetings where we go to every region of the state quarterly, and we have a different menu of presentations each time. And it's also a good way to network with local health departments and other community partners. Also, during the pandemic, we discovered that we didn't have a really good communication system in place with the health officers, and they were the ones making the quarantine and isolation decisions. And so we now have what is called HOOK, Health Officers of Kansas, and they meet monthly and have different topics and network. And so if anyone ever has a topic that you think would be really valuable for health officers, we would be happy to include you. Public Health Connections is a monthly electronic newsletter that is chock full of information. We also do a workforce assessment every 3 years. And so we're coming up on the time where we're doing that. We ask a lot of questions that are related to health equity and cultural competence. Last time we did a piece on racism where we were gauging what the workforce development needs are. And so those results we use specifically to design trainings and topics at our annual Governor's Public Health Conference, which is held annually in March. And this year it will be March 4th through 6th in Wichita. And so that's a great opportunity. We're planning to have keynotes and breakout sessions related to health equity. So another great opportunity to network with local health department and other public health professionals. And then, as I mentioned, during the pandemic, we were able to grow our staff. So we now have a regional public health nurse or specialist serving every region of the state. So I would urge you to connect with them if you haven't. And then related to what Charlie talked about, the Public Health Infrastructure Grant, we are in the process of awarding $10.7 million directly to the local health departments. And so I think there are many opportunities there, and some that I thought were relevant. Just so there will be system-wide training opportunities, but some that I extracted from our spreadsheet. So 7 local health departments are hiring community health workers, 35 are implementing self-care initiatives, 13 are doing tuition reimbursement for their staff, 6 are doing loan repayment for their staff, 32 are implementing mental or behavioral health improvements and supports, and 49 are wanting to strengthen community partnership development and engagement. So I think there are a wealth of opportunities there. And so just wanted to share those.
Thanks, Christy. Jade or Captain Davids, any reflections about opportunities for public health?
Yeah, absolutely. I'd like to delve a bit further into the partnerships aspect, because I came into the department in December of 2021, and immediately when I came, I was, I kind of made it our mission within the center to gain feedback on how to sustain those partnerships and how to best address more of a bidirectional feedback loop of communication with KDHE and some of our partners that have been sustained and gained throughout the pandemic. One area where we saw a large scale opportunity was through our state health improvement plan. And we've really taken a quality improvement approach to bring more folks into that plan and for them to see themselves within that plan. And whether that be via surveys, focus groups, interviews, we're gaining more of an insight into how to best communicate and get information out to folks regarding some of our state health priorities. I'll also say that we have taken approaches to look at how we communicate with other state entities. So recently we've underwent some work regarding health in all policies so we can better address social determinants of health. I think that's one key area as we continue to delve into some of the disparities that we've seen from the pandemic or that were exacerbated by the pandemic, that we've had an area of opportunity, connecting more with our folks at transportation, at the Department of Transportation, even in commerce when it comes to broadband access. And digital equity, there's lots of conversations surrounding that. And so we're engaging more at the state level with other state entities, more at a grassroots level, bringing folks to the table and really kind of taking a seat back and listening more in order to better inform our decision making and ensuring that those folks that we're bringing to the table, they're being compensated for their contributions and they're really feeling like they're being heard. And so for us, that's really just continually asking the right questions and ensuring that we're taking that information and we're really, truly moving it and doing something with it.
Yeah, there's been so many great things shared, and don't want to duplicate what's already been said, but just kind of want to build upon all the great work that the state and local health departments are doing. You know, from our perspective in the federal government, when, you know, the pandemic happened, really figuring out who the players were, and HHS was working alongside FEMA and really learned that emergency management and public health don't always talk at the federal level all the way down. And so our role kind of became bridging that gap and making sure that health had a seat at the table. And that was really powerful, and it's continued on. So we established, I think somebody mentioned, you know, building these partnerships and relationships that have continued on. And during COVID, we established, you know, Region 7 public information officer calls at the state level, the immunization directors, the lab directors, and those calls were so awesome and was kind of a model for what we were doing here in the middle of the country, because they were sharing, like, you know, how are you communicating in rural health? How are you addressing this issue? What are you doing as far as getting, you know, testing supplies? And so it helped me be able to push that information back up to, you know, DC and say, hey, here's what the real boots on the ground, what the challenges are. But it also helped the states be able to share these best practices and really lean on each other. And so we've continued those beyond the pandemic. We moved them. We were meeting, I think somebody said before, daily. We were meeting like weekly at one point and then kind of every 2 weeks. Now we're quarterly. But all of those, you know, kind of Region 7 state partnerships that we created, they want to continue just because they're learning so much from each other and able to help each other. And I sit on them. I convene them, but I sit on them and really just learn. And then also if there's any, you know, gaps that are identified, I can go back to CDC or other HHS resources to help fill that. The other piece that we're just getting into, what we learned is, you know, the community, the role of the community partners. And we do have a minority health analyst here at our office and works with all the states. But really getting into the community health worker space, which I know a couple of you had mentioned, convening kind of like what we did with the other groups, convening a Region 7 collaboration where people can come on and start networking and learn from each other. And how are you doing billing? How are you implementing this? And so I think the opportunity here is just continued on to build those partnerships, to help each other, to share best practices, but also we're in the spotlight. We've gotten no break after, you know, COVID, then was monkeypox and now syphilis. And so I think as much as possible to really be able to show and shine, not just like what the state or the local is able to accomplish, but what we as public health collectively are able to accomplish is really, you know, brings that to the forefront of the community, and having language that people understand. And, you know, they might not realize, you know, that they have, you know, safe drinking water, but using those opportunities to say, hey, that's a public health issue. I think there's just a lot of excitement around where to go from here and a lot of opportunity that we can just build upon.
Yeah, thank you, Captain Davids. I appreciate that. I think you all at various times have commented on just some of the challenges that were experienced, and Captain Davids just referred to how the pandemic really shined a light on public health and in particular governmental public health, and that there are some implications for that. So when you think about the future for public health, what do you see as, potential threats or additional challenges that we might be encountering? And I also, in thinking about who we have in the audience with COVID, these folks all represent different parts of local public health systems and broader state public health systems. And I wonder if you might also, when thinking about threats, talk a little bit about how other partners can help be allies and work together on those threats. And Christy, I wonder if you would get us started.
Sure, I'd be happy to. So, I mean, I definitely think one of the threats is just not really learning from what we experienced during the pandemic. And we've talked about this for a long time before the pandemic. We talked about how public health was invisible, and we've talked about now we're in the spotlight, and I really think it's time to take advantage of, so people know what public health is now, and really framing what we want that message to be. And so really making that a huge effort. I also think just with the public health infrastructure grant, it is unprecedented funding, and like we need it to be transformational. Like we need public health to look different and to be improved 5 years from now. And so and like it could be like a once in a lifetime opportunity for that funding. There might be hopefully more funding coming down because we know that public health has been underfunded for so long. And so I mean, I just think the more we can show how we can improve public health with that funding, then the better things will be. So I think not thinking transformationally, not being innovative, not really making that money work for the system would be a huge threat.
Yeah, thank you, Christy. Others on the panel?
Well, I guess I can jump in a little bit and kind of talk a little bit about this from a systems perspective. I mean, the reality is that Kansas is not alone in this regard, but we have 105 counties and we have 100 local health departments. As I said at the very beginning, I have a large health department. We have a lot of staff. It's never enough, but we have a lot of staff and a lot of capabilities. But a large percentage of the health departments in the state, and Christy can correct me if I'm mistaken here, but I think 50% have fewer than 5 FTEs. And if you think about the tremendous responsibilities that public health has, and whether it's a small community or a large community, it's really difficult for a very small health departments with just a handful of staff to manage all those responsibilities. Now, the truth is that I mentioned that we have an entire epidemiology division. Most health departments in Kansas don't have a single epidemiologist that's devoted to it. And it's not necessarily that they all need a full-time epidemiologist serving just their county or their community, but they need to have the services, the expertise, the capabilities of an epidemiologist available to work in their community. Same thing with communication specialists, same thing with billing and accounting and all those other things. If we think about the competencies that are needed in public health. And I think that we've been working at a systems level for many years to try and get those capabilities, those capacities enhanced throughout the entire system. And quite frankly, we're just not there yet. The infrastructure funding that Christy mentioned, the reality is not all the health departments took advantage of that opportunity to take that funding. And there are lots of reasons why that's the case. I think we're trying to figure out exactly how we can ensure that all the health departments have the support that they need. But I think that that's a real threat, that we may not be able to make this transformational for everyone, unless we can figure this out. So I think that that's a real threat. The other thing is, going back to the bad rap issue, the reality is that public health did suffer a little bit in terms of its image during all this, rightly or wrongly. I mean, certainly there were things we could have done better along the way, but we really, there's a segment of the society, of the communities, that don't trust us, don't want to have anything to do with us, are not going to believe anything that we say, and we have to figure out a way to maybe not change their minds, but at least overcome that resistance, so that we are a trusted entity in the minds of the community, because the reality is we do a lot of important work, and if the public is not trusting in us, and is not willing to provide us the resources that we need, then I think that's a real threat.
100%. That was what I was thinking the first thing when you said the threat is the loss of trust that we as a public health entity have from the community. CDC just released the other day that we're at the highest exemption rates for vaccinations. And so I think a lot of this is going back to the basics and explaining what we know and on a language that people that can understand, and just rebuilding that trust is key. And then also, the workforce. We had so much turnover, and there was a lot of, threats to safety for public health. They didn't get a break. It's just been kind of continual. And so really, I think putting resources into the workforce. I know some of our states are doing this at the state level. They are implementing programs like HOPE, where they're really focusing on giving their employees, training on resiliency, and also putting back in boundaries. We lost a lot of boundaries during COVID when we were all available 24/7 and working nonstop, 20 hours a day. And so, being able to let your staff know it's okay to pull back, that we're going to work these hours and be able to provide, like work-life balance and vacation time again. But I really think, the burnout and the trust, those are the two biggest threats that we're seeing on the federal side, and something that we're very concerned about on all levels.
And I can delve a bit further into that trust aspect. Adequate provision of culturally and linguistically appropriate services and responsiveness is key to this. If that information isn't timely, we are seeing adverse health outcomes, inequities, and subsequent disparities. And so it's really critical for us, as our state becomes more linguistically diverse, especially, to make sure that the right to health information continues to be spread, and that folks know that it's enshrined in laws and regulations to protect access to timely information. At our department, we really built up our culturally and linguistically appropriate services program, hiring a dedicated specialist to really look at language access. We're working on a health literacy survey in multiple domains, thanks to some of our partners and just feedback that we saw from our state health assessment, that throughout COVID especially, folks did not have access to timely information. They didn't understand the information that was being provided to them, or it wasn't being provided in the language in which they spoke, was their first language at home. And so for us, it's a real opportunity for us to look at that and get feedback from folks on how we can improve the communications that we are putting out, whether that be reports, whether that be our state health assessment and our state health improvement plan, looking at interpretation services, ensuring that those services are timely, the ways in which we post, folks' rights, and just really continuing to advance our work within this area to ensure that folks internally here at our department have that information, within our workforce have that information, and know what to do to best address this need when we're supporting our communities.
Yeah, thank you, panelists, all for commenting on that. And Jade, in particular, I feel like you did a nice segue to my next question. So thank you for teeing that up. Our group, this COVET group, has been focused on equity throughout our time together. I wonder if you might talk about the landscape of work to address equity. And I think Captain Davids, you've referred to some things. Jade, you've referred to some things, as well as Charlie. But are there any additional pieces of work that you'd like to highlight or sort of foreshadow as upcoming? And Jade, I'll hand it to you to add to anything that you started us off by thinking of before others.
Yeah, I would love to. Really looking at equitable resource allocation, I think is critical. A lot of the feedback that we heard from folks throughout the pandemic was they didn't feel like, the funding that we were seeing throughout the pandemic was getting to the communities that needed it the most. And that really told a story for us. And so looking at things from a quality improvement perspective, when I came into the department, we really started to look at what our processes were internally and how we can best support resource allocation. And so having dedicated staff members looking at whether it be our procurement process or a policy or procedure and how that information is disseminated, or what the language says, or what the stopgaps are, it has been really critical. I think another key area just involves our program design from a quality improvement perspective. We're really adopting approaches that acknowledge interconnected nature of like various social determinants of health. So before I mentioned some of our work in health and all policies, we formed a wonderful partnership in late 2023 regarding some of the broadband work, and my team really helped to disseminate a lot of the information that was coming down regarding some of that BEAD funding. And so I think it's really us leveraging the partnerships, but also looking at resource allocation and how we can best ensure things like the public health infrastructure grant and the funding that we're seeing is getting to the areas that need it the most, the folks that are doing the work within those areas especially. And, we don't know what we don't know. And so it's really critical for us to be asking questions. I would also be remiss if I did not mention community health workers. As a result of the COVID-19 disparities grant, we were able to develop our KDHE CHW section. And of course, some of that funding also helped to support the work with our wonderful partners at KUMC COPE. So continuing to leverage that workforce, folks within those communities to help meet the needs of, different areas of our state, I think is a really great opportunity for us. And I think we need to continue to just really ensure that our aim is on how to best support that work.
And others?
Well, I guess I can just jump in and say, I think that in terms of equity, it's not going to just happen. I mean, it really does take intentional effort to ensure that we are continue to advance health equity and that our programs and services are addressing that. One of the things that we did is that we actually established a new position. Position's been in place for about a year now, so we have a person in our department that's dedicated to working on health equity issues, and the work is really focused internally as well as externally. So as an organization, some of the things that Jade mentioned in terms of the kind of the internal processes and so forth, we're going to be taking a look at that. We've done an organizational equity assessment, and we are in the process of doing professional development and learning as an organization, and working in close collaboration with our county human resources department to deliver that training and having lots of conversations around equity issues. So I think that's important. The other thing I'll mention is the importance of community engagement. I think that we've continued to learn the importance of having the community engaged in our programs and services, and quite frankly, the decision making we make about our programs and services. So, for example, one of the recent things that we've done is develop a child care coalition, and we have child care workers that are actively involved, and we help us work through a grant that we have received to help improve childcare access and quality in Johnson County. And those meetings are held when childcare workers are available. They're not available 8 to 5. So we're meeting in the evening. And I think that the reality is that that's the approach that we need to take, is to make sure that that the community members don't just have a seat at the table, but they're involved in the decision making. That there's power sharing in terms of planning and decision making.
Thanks, Charlie. Captain Davids, anything you want to add? I know you've talked about a few things, but anything to add?
Yeah, I will say, when I mentioned earlier about the focus, the federal focus on including health equity into everything, that really they're looking at that, when they write policies and also grant opportunities. And from our perspective here in the region, we have a couple of initiatives on harm reduction, maternal health, but also climate change and health equity. And these were new offices that were established in the last few years, and they sit underneath the Office of the Assistant Secretary for Health. So it's the Office of Climate Change and Health Equity, which they call OCHE, because we're the federal government and have to have an abbreviation for everything. And they also established the Office of Environmental Justice, and they don't have a great abbreviation for that one, but both of those offices are really, health equity is in the name of climate change, and a lot of people in our states don't want to talk about climate change, or they might not believe climate change, but we can say that there is adverse weather events, and that disproportionately impacts people of color and underserved communities. And so we are working on with our states and also across the federal government. There's some Justice 40 programs and funding, which specifically HHS has 13 programs that it's 40% of funding will go to these communities that are looking at health equity and distribution. So I will say, like I said before, it's kind of weaved into all that we're doing, but really at the policy and the funding level. And then also to follow up on what Charlie said, really working with the communities and hearing what the needs are. And so we as the federal government, we don't always go straight to community. We go, from the state to the local. And but if you have any concerns, you can always reach out to us. We also in our region have a regional director, Director Joseph Palm, who represents the Secretary of Health. So between his office and my office, we're here to represent the secretary and the assistant secretary, and can always assist with any funding questions that you have or any concerns or needs as in any of these initiatives or projects.
Great. Thank you. We are bumping up to only 3 minutes remaining, and I feel terribly that I'm going to shortchange this question. But I wonder if each of you might close us out by giving us a 45-second or so reflection on your hopes for public health going forward, and also how groups like COVID and other members of the local public, or not local, but public health systems might be supportive of advancing those hopes. Christy, I shortchanged you on the last question, so I'm going to start you off, if that's okay.
Yeah, sure. That's fine. That is a big question. But I think groups like this can be really helpful as far as advocacy for public health. We need champions and we need people who support our work. We need people who engage and partner with us. Public health is one entity and cannot do everything alone. And so just your partnership is valuable, and we just need to keep building on what we have and what we've learned. And I think the future is bright for public health. I'm excited.
I'll jump in real quick and say kind of my hope and goal is to continue building relationships that we've already established during COVID, but creating new ones as we move forward. I do want to highlight our office has a HHS virtual office hours every month where we bring on, CMS, SAMHSA, HRSA, and they report out like new funding that's coming down the pipeline, any trainings or resources, Grants 101. And so if you're interested in attending that, please come or share it. If you sign up to attend and you're not able to make it, you'll still get a copy of the questions that were asked in the chat. But it is a great resource to kind of know what the feds are up to, and also just a direct link to the feds if you have any questions or concerns. So I'll make sure Dr. Garcia has that and can share it with everyone.
Thank you. Charlie or Jade, do you want to go next?
We talked about some of the threats and the opportunities with this work, and I think that one of the key levers of support is partnerships in groups like this. And so that absolutely gives me hope. It's wonderful to see the partnerships develop into additional partnerships, and then just kind of seeing that expand throughout the state. It's amazing. I can call up someone and they'll immediately connect me with folks that I haven't had the opportunity to engage with. And so we're getting to learn more about our state and the wonderful work that's happening within our state. And I got to tell you, as someone that is coming into this work here at the department from 2021, I'm amazed at the things that I've been able to see thus far. And I just know that there's more out there. And so for myself, that makes me hopeful. I think there's a lot of opportunities for us at the state level to be able to engage at more of a grassroots level. And so I think an imperative for us is to really get out there, get more boots on the ground, and hear stories from folks who are most impacted by a lot of the disparities that we're seeing within the state. But definitely from a resource standpoint, whether it's navigating policies within the state, the partnerships continues to be that key lever, and that certainly keeps me hopeful.
Thank you, Jade. Charlie, do you want to?
Sure. You bet. So I guess a lot of great things have already been said. I just echo the sentiments about the partnerships and again the importance of engaging the community in this. I guess the final thing that I'll say is that I think that there's a real opportunity for us to demonstrate the value of public health. And Vicki, as you're very well aware, this is an important issue for me to ensure that we are incorporating performance management and quality improvement in the work that we're doing, and evaluating our programs and being very transparent about that, so that we can continue to advocate effectively for the resources that we need to make a difference in the communities. It's not going to. I think we're in a different era now. I don't think it's going to happen just because we say, just give us the money, we'll do good work with it. I think that we have a responsibility now to demonstrate how effective we're being with the resources that we're given.
Really, really important point. Thank you all so much for your contribution today. I have to say I've looked forward to this all week, and you all did not disappoint. It was great to hear so much about your thoughts about where we've been and where we are going. So thank you for today, and also helping us wrap up our year of COVID. Colleagues, I hope that you will join me in thanking our panelists. Also, if you have questions for them, and you're welcome to put them in the chat. I don't know that we'll have time to answer them. And then I am going to close this out, soliciting any announcements that any of our COVID members have. I also just want to thank our interpreter today. I feel like we've worked you overtime, and I'm really grateful for that. Any announcements? All right, hearing none.
I saw a hand up. Amy, was that no? Oh, that was a goodbye. All right, no announcements. Now that I've thoroughly embarrassed Amy. Thank you.
All right. Thank you for your time today, everybody. And we'll be sure to get information out from this session that I think has been shared in the chat. And we'll look forward to seeing you next time.